This conference will now be recorded.
Okay, welcome all in the class. So it's a very important topic we are doing today, that is a maternal collapse in pregnancy and preparium. Very important for both MRCOG, EBCOG, because the stations are there in the exam and a lot number of questions are there. So understanding of the topic is very important. So I'll be explaining every part in details, and then the question answer discussion, so that the topic has to be very clear. Then you can do well in the exams. Now, coming, so maternal collapse is acute, event involving cardiorespiratory system and or brain, causing a reduced and absent level of consciousness at any point during pregnancy and up to 6 weeks postpartum. Okay, so very important to know that we used to think that collapse is in the pregnancy or whatever, but it is like maternal collapse definition is it is involving it can involve three system: cardiorespiratory and brain, and they should it is up to whole pregnancy in 6 weeks. So this will be the definition of maternal collapse. Now, incidence. So incidence of is what the guideline says is 1 in 36 maternities. Okay, and this is and 25 percent of the cardiac arrest in the pregnancy are secondary to anesthesia. These are green top guideline numbers. So it is important that mm, you should know. And if cardiac arrest that were due to anesthesia, then revival rate was very high, 100%. We can understand because everything is happening on the table, patient is on the theater, so all the team is already there. So if anything goes wrong, cardiac arrest happens at that table, will be managed very well. Okay, then another question, another question, um, that I have seen in the books also. What is the most common cause of maternal collapse? That is the vasovagal attacks and epileptic seizures. So many people they will write hemorrhage, or they will write sepsis something, but answer is this. So vasovagal attacks and epileptic seizure are the most common causes of maternal collapse. Okay, and whenever the collapse, so UK has developed, you must be knowing, there is a warning score system is there. That is a obstetric modified warning score system, that is called as a MEOS chart. And it has various parameters, and they are different for and the parameter range is different because that is according to the physiological changes in the pregnancy. So whatever monitoring is done in here in the pregnancy is because in the MEOS charts. Okay, then very important to know what are the physiological changes occurs in the pregnancy, though understanding is important. And these numbers are important because from these numbers, in part 1 EBCOG and part 2 MRCOG, you will find questions. So like plasma volume increased by 50%. Because of that, my patient has dilutional anemia and the reduced oxygen capacity. Heart rate increases by 15 to 20 beats per minute. And apart from this, cardiac output by 40%. This everyone remembers, but yes, you have to revise this. Uterine blood flow is 10% of the cardiac output at term. Because of the progesterone effect, so there is a vasodilatation, so systemic vascular resistance is usually decreased. Okay, now blood pressure, arterial blood pressure decrease because of there is a vasodilatation and effect of progesterone. So usual effect is decrease in the blood pressure, and decrease in the blood pressure will be by 10 to 15 millimeters of mercury. Venous return will be decreased. We already know the reason, because the uterus is compressing on inferior vena cava. And oxygen consumption increased by 20%, and residual capacity decrease because of the compression. and like laryngeal edema is increased, and lower esophageal sphincter is relaxed. Because of that, that belching, aspiration are quite high. Okay, and there occurs diaphragm gets splints, then it compresses. Because of that, residual capacity will decrease. Okay, and the weight, we already know that pregnancy there is increase in breast size. Because of that, intubation becomes difficult, and when we give CPR, then that will also becomes very difficult. So this is the same in the form of a picture. So that breast enlargement is there, laryngeal edema is there. Because of this difficulty in intubation, so you would require experience anesthetist for that. Risk of aspiration is high, so airway has to be secured very fast. Okay, aortocaval in compression, so venous return will decrease. Because of that, whenever we are doing uh, resuscitation in the pregnant woman, we apply left lateral tilt, or we do the manipulation of the uterine manipulation is done. Okay, apart from this, uterine flow is 10%. So what if the bleeding occurs, there is a predisposition to hemorrhage and hypovolemia, and aggressive fluid replacement will be required. And here, like anemia is there. So because of the increase in cardiac in the plasma volume, there occurs dilutional anemia, so oxygen capacity is less, so they become deoxygenated very fast. Apart from this, increase oxygen supply to the fetal placental unit also. Because of that, very fast the pregnant woman will develop hypoxia. So as early as possible, we will offer high flow oxygen. So whenever there is a collapse patient you are dealing with, so high flow oxygen 100%, 10 to 15 liter per minute has to be given. So this is the basic, that why we are putting patient, why we want to secure airway early, why we are doing uterine displacement, or why we want to intubate or give oxygen early. Now again, this is the same thing. So changes in the lung function, diaphragm splinting, increased oxygen consumption make pregnant women hypoxic fast, and ventilation becomes difficult intubation because of the laryngeal edema. Because of the lower esophageal sphincter become relaxed, so risk of aspiration is very high. So these are the like basic physiology here. Now the same thing, intubation becomes difficult, we already know, because of the laryngeal edema, difficult uh, mm, like like breast. So everything, the weight gain in pregnancy, a large breast inhibits the working space and the laryngeal edema. Because of this condition, intubation becomes very difficult in pregnant women rather than any non-pregnant woman. Apart from this same aspect, as the lower esophageal sphincter gets relaxed, because of the risk of aspiration, regurgitation are very high. And this will be further added by increased pressure, intra-abdominal pressure is increased. Why? Because of the gravid uterus. During labor, opioid usually when the in the labor, as a pain relief they are using pethidine opioid, so that also delays gastric emptying. Because of that, gastric pneumonitis, aspiration pneumonitis, that is called as a Mendelssohn syndrome, is very common. And this how we can reduce this aspiration risk or Mendelssohn syndrome, this also comes as a question, where they will give you they will give in a history that there was a very difficult intubation, many times repeatedly intubation was tried. So this kind of key picture will be there, and answer will be will be Mendelssohn syndrome. So the risk, how we can minimize Mendelssohn syndrome, by giving effective cricoid pressure. Antacids or S2 antagonist can be used beforehand if the patient is requiring an intubation or GA. So this way we are able to prevent it. That is the aspirations syndrome or Mendelssohn syndrome. Question, though one or two times I have seen question from even from the Mendelssohn syndrome also. Now, just a quiz. So, how much blood healthy women can tolerate without showing any symptoms? How much healthy women can tolerate without having any symptoms? Any whatever, any idea
Ma'am,
or
20%,
any guess? 35.
20.
35, 35. So this is from the Green Top guideline only. Healthy women can tolerate remarkably well, can lose up to 35% of their circulation before becoming symptomatic. Often the maternal tachycardia will be the only sign of hypovolemia until very late in the hemorrhage. So blood tolerate loss is tolerated less well if patient has previous anemia or any clotting problem is there. So this much. So whenever we see any bleeding in the pregnancy, a small amount of bleeding, but we have to be very careful about the situation. This number is from the GTG and whole line from the Green Top guideline only. So just a number that you should remember, good number. These are the reversible causes of collapse. Everyone knows it, and this table has to be remembered by heart by the MRCOG part 3 people, because this question is asked in the exam. Tell me the reversible causes of collapse. So everyone knows 5H and 5Ts. 5H will be hypovolemia. At least in the exam, say one example. For example, bleeding, hypoxia, such as cardiac event, cardiomyopathy, myocardial infarction, aortic dissection. Hypo and hyperkalemia, or hyponatremia, hypothermia. For these are the four H's, and four T's will be thromboembolism, toxicity, usually local anesthetics, magnesium sulfate. Apart from this tension pneumothorax, usually it occurs in trauma or suicide cases, and tamponade also occurs in trauma and suicide cases. Eclampsia and preeclampsia, why it occurs? Because there is an intracranial hemorrhage. This part, three people has to remember by heart, because this question was asked in the viva exam. So it appears we know everything, but when it comes to speak out, there would be thought block if you have not remembered them nicely. Now, a few things I would go according to the guidelines, so revision becomes easy. So, hemorrhage incidence 6 in 1000 maternities. This number is not that important, but just I read it, put it from the guideline. Causes of MOH, major obstetric hemorrhage, we know APH, PPH, a uterine rupture, abruption, ectopic. Rare causes will be splenic artery rupture, hepatic rupture. Many times in the you will find in your EMQs or SPA, there would be some scenario of hypotension and right quadrant tenderness, something like that. So it's hepatic rupture. I have seen a question, so you have to think widely when you do your EMQs. So hepatic rupture can be the answer. And now coming to the amniotic fluid embolism, this is a very important topic. And when we see the questions, everything appears very easy, like we will be able to do it fast, but still the mistake happens. So amniotic fluid embolism is a clinical syndrome. So just see, whenever you mark your answer as amniotic fluid embolism, you have to see these things. There should be hypoxia, so they will give you a low oxygen saturation. They will give you feature of low blood pressure, hypotension, or bleeding from anywhere else. So this is HHC, hypoxia, hypotension, coagulopathy. If you find out in your scenario these three things are coming, then you are dealing with the amniotic fluid embolism. Why it happens? Because the fetal antigens rapidly entering into the maternal circulation. These are the risk factor. SBA can come from here. So this is important to just cesarean delivery. So it can happen in cesarean also. Okay, multifetal pregnancy, abruption, abdominal trauma, placenta previa, uterine rupture, cervical laceration, forceps, and polyhydramnios, induction of labor, or any oxytocics are used. So these are the risk factor for these are the risk factors for amniotic fluid embolism. You will find some of them in your question scenario. Now, what could be the symptoms? So, usually it manifests shortly after labor or within 30 minutes of delivery. This is a key point, or you can say buzzword. This 30-minute of everything happening in 30 minutes of the delivery. First sign will be what? Sudden cardiac arrest. Patient will develop hypoxia. Okay, oxygen will be less. So there would be dyspnea, tachycardia, tachypnea, hypotension. So all these features of low oxygen and then hypotension, low blood loss is coming. And coagulopathy will be there. How it will be seen? Either bleeding from the uterus is coming, or bleeding from the sites of injection incisions, or venae puncture. Okay, so basically you will have these are the triad that develops after delivery: hypoxia, hypotension, coagulopathy. If you are finding combination of this, you have to, and you find the risk factor from the table I have shown before, the answer will be amniotic fluid embolism. And like autopsy, if it is done, the fetal stem cell will be detected, and the treatment is supportive. So what is the treatment for it? Like this is everything from the guideline. This is this part I from GTG. There is no effective treatment. The treatment is supportive, so there should be resuscitation and supportive measures. So if they ask you in the question like what is a treatment, so answer will come from resuscitation and supportive measures. If sometime arrhythmia will develop, so standard treatment will be done. And sometime if the inotropic support may be required. Fluid load overload to be avoided, because what will happen, this will cause pulmonary edema. Recombinant factor 7 can only be used if the hemorrhage is not getting controlled. Promptly delivery, if by now if the patient is not delivered, please take out the baby and placenta as early as possible. Okay, so and then PPH will be there because of the uterine atony. Some other therapies are there, but the evidences for steroid, heparin, plasma pheresis and hemofiltration, the effect for this, the evidences are not there at all. Okay, so but these are used. So now you can understand that amniotic fluid embolism diagnosis will be from triad of hypoxia, hypotension, coagulopathy. Treatment is supportive treatment. Apart from this, if the baby is undelivered, please do deliver uh, the baby and deliver placenta, take out the baby and placenta as early as possible. So this is about the amniotic fluid embolism. Very important to know, because a lot number of questions come from here. But if your knowledge and idea about about the pathophysiology and the treatment is right, your answering of the question will become very confident. Okay, now cardiac causes. So cardiac causes is the most common cause of indirect maternal death that we know already. And main causes will be ischemia or sudden arrhythmia. So ischemia and sudden arrhythmia will cause cardiac death. Okay, apart from this, congenital and rheumatic heart disease are also increasing because of the increased medical facilities. So people these people are getting pregnant also. So we see them in the pregnancy on high risk obstetrics. Women with the mechanical prosthetic valve are increased risk of complication. Cardiomyopathy, dissection of coronary artery, LVF, infective endocarditis, and pulmonary edema are all other causes. Very important to know the aortic dissection, because many answer questions you will find an answer will be aortic dissection. So usually it is associated with inherited aortopathy, where either it will be Marfan syndrome or Ehlers-Danlos syndrome. Both are connective tissue disorders. So because of the pregnancy, demands, there will be a like tear in the wall of aorta. So that is dissection. So how the patient will complain? So these are the buzzwords you will find in the answer: tearing chest pain, central chest pain, or intercapsular pain. So these are the few things you will find as a buzzword in the answer. Now there would be new cardiac murmur. There would be wide the pulse pressure because of mainly secondary to systolic hypertension. There could be possible that like limbs have got absent pulses. Maybe rate of pulse will be different, or variation in blood pressure in both limbs. This could be there. Echo usually helps in diagnosis. So if your scenario gives you the buzzword of tearing chest pain, central chest pain, central or interscapular pain, or new cardiac murmur, or pulses are different, or BP is different in both limbs, so you are dealing with the aortic dissection. You have to put the answer as aortic dissection. So this would require surgical correction. Each hour will delay the mortality by 1%. This is written in the guideline, that the number is not important, only just for the general knowledge. So aortic dissection you will find in many answers. You find many questions answer will be aortic dissection. So look for the buzzword, look for the scenario, and answer the question. Acute coronary syndrome, that is the myocardial infarction. So we know the presentation, there will be dyspnea, pain, chest, reduced exercise tolerance. ECG and troponin I and T level helps in pregnancy. Usually troponin I level, it helps in detecting the condition. Initial management will be analgesia, GTN, oxygen. First line treatment would be PPCI, that is a percutaneous coronary intervention with the involvement of acute cardiac services. So this is the about MI. But about the MI, we do have a talk of 2013. I have explained that much more details in cardiac heart disease in pregnancy. But yes, we look for the buzzword, and sometime MI or acute coronary syndrome will be the answer of your questions. Very important is the cardiomyopathy. Cardiomyopathy, like you will find the cardio in it will be in the many questions answer. You will find a detailed of three types of cardiomyopathy I have explained in heart disease in pregnancy. Here I'll be just speaking a few things only. So the patient usually has breathlessness, unexplained tachycardia, edema, peripheral edema, and symptoms of cardiac failure. How you will diagnose? By echocardiography. Involvement of cardiologist is must. And here chances of embolism is high, so VD prophylaxis to be considered. The patient who have any cardiac condition, usually we don't allow them to push. Okay, so we aim for passive delivery. So we don't allow to push them to push, because we don't want to put pressure on the heart. Now, sepsis. This is very important, because many times, though you do have a guideline about it, many times your answer will be sepsis. Sepsis usually occurs because of the substandard care. And bacteremia, which is present in absence of pyrexia, raised blood count, can progress to sepsis or septic shock. So, common organism in obstetric sepsis is streptococcal group A, that is a gas, or group B, GBS, and group D. Okay, so Streptococcus group A, B, D, and Pneumococcus and E. coli. So these are the most common organism implicated in maternal sepsis. Apart from this, we do this is important and necessary for both part 2 and part 3 people. Usually the sepsis care bundle, we do have a sepsis 6 care bundle. Usually it is applied immediately or uh, or uh, or within 6 hours. Multidisciplinary approach, midwives, consultant obstetrician, anesthetist, hematologist, intensivist, microbiologist to be involved. Lactate has to be measured. Blood culture to be taken before antibiotic administration. Broad spectrum antibiotic within first hour. And apart from this, mm, like fluid resuscitation and if the lactate if the hypotension is there or lactate is more than 4 millimole, that means severe sepsis is there. In that situation, rapid administration of crystalloid 30 ml per kilogram uh, per hour to be given within 30 ml per kilogram. With this rate, it has to be given 3 hours within 3 hours of diagnosis. If the adequate replacement has been done and then still there is a response is not there, consideration for inotropic or vasopressor like a non-adrenaline adrenaline uh, can be done or inotrope in form of dobutamine to maintain, because we want heart to contract and the mean arterial pressure has to be more than 65 millimeters of mercury. So these are the steps of sepsis 6, like a sepsis care bundle. So do lactate, take cultures and swabs, give them spectrum antibiotics, and correct hypotension. So rapid hydration of like minimum 30 ml per kilogram of crystalloid, and it has to be done within 3 hours of diagnosis. This is followed by adding vasopressor. Now further management would be if the lactate still it is not responding, lactate is more than 5, and then in that situation, uh, variable of fluid status to be diagnosed by LIDCO, that is the transesophageal Doppler or lithium dilutional cardiomyopathy, cardio output. This is a new sort of a new technique, but previously what we were using to as a marker for the fluid replacement was central venous pressure, but now they are saying that variables of fluid status such as transesophageal Doppler or lithium cardiac output, like lithium dilution cardiac output, so the LIDCO. So these are the methods. Okay, so this is a new change. Apart from this, steroids can be given at the end if the hydration is done, resuscitation is done, and vasopressin is done. If the patient is still not responding, then what we do, we give steroids. Oxygen saturation to be maintained more than 94%. If the patient is anemic, hemoglobin less than 6 7, then blood transfusion also. So supportive therapy other part would be removing, doing something, finding out and removing the septic focus, and the blood products if it is required, and also venous thromboprophylaxis. So this is like management, basically the sepsis care bundle or the management of septic shock. This is both important for part 2 people, and for part 3 people it is very very important. So you have to learn this, understand this very nicely. Any question till now?
Ma'am, can you explain this lithium dilution cardiac output? How is it done?
Basically uh, with a transesophageal Doppler, they're doing some Doppler and they're measuring cardiac output. This is a previously when we used to give fluid access like vigorously, then we used to measure CVP, that we used to say central lines. Okay, so that was the marker that will help us in finding out whether how much fluid we have to give, but CVP technique is not used now. So this is a new technique, they're measuring cardiac output.
Right,
Trans
ma'am. So
esophageal LIDCO, yes.
this
These
is
are the
for
technique of
monitoring.
measuring. Yes.
This is the technique for monitoring the intravascular pressure in sepsis specifically.
No, particularly in sapnis, I would not say it can be used anywhere, but this is the measurement for measurement using as a marker that will guide the fluid replacement. Previously we were
Okay.
using CVP, but now we are
CVP
using,
monitoring.
yes, CVP. Previous it was the CVP, but now it is LITCO.
Okay. Thank you.
Okay. Now, very important, drug toxicity and overdose. You will find a lot number of question here, and so substance abuse, the most common. The people, they will be taking some drugs or substance abuse is there. Therapeutic toxicity is magnesium sulfate. Usually it occurs if the renal impairment is there, and local anesthetic toxicity. And toxicity usually occurs of like local anesthetic or lignocaine when as a result of invertent um, injection, venous injection, or if there is a systemic absorption is there when we give epidural local filtration, then it can happen. So it may cause, and if IV is given, then cardiovascular collapse may occur very rapidly. Because of that, you would have seen that in your part 2 exams, there is a question. Lignocaine, the dose calculation, maximum dose we calculate before give lignocaine. That is 7 milligram per kilogram of body weight. If lignocaine with epinephrine is there, then okay, maybe I'm saying reverse. So it is a 3 gram per kilogram of body weight. So for I think plain lignocaine, the dose calculation is by 7, and lignocaine with adrenaline, the dose calculation is by 3. So I would review it. It is 7 or 3 only. What is for plain? One is for plain and one is for lignocaine with adrenaline. So the basic take home message is that whenever we are offering a lignocaine injection, we always do both, dose calculation. We calculate the maximum dose that can be given to the patient. Because of that, there are, though in gynecology and obstetric, we use lignocaine only for episiotomy repair, so we are already using very less amount, like hardly we use 5 ml or 10 ml. Okay, but those people who are doing surgery, like in local anesthesia only, they had to give local repeatedly, they have to put injection. In that particular situation, they have to be very careful for lignocaine toxicity. So because of that, there is a formula for lignocaine dose calculation, so that it is so important. Because of that, whenever any person is doing any of the procedure in local, they should not never take it very lightly, uh, because it is very fast, the toxicity will occur. And basically it happens when IV injection is done, because dose calculation we do, but the problem is with IV injection. Now lignocaine, you will find this question in the exam, yeah, like a lot number of questions is SB and AMQs. So how you will find out that you are dealing with the local anesthetic toxicity? So what patient will complain? Patient will complain lightheadedness, sort of a confused by sedation or confusion. There is a circumoral or tongue numbness. There could be hallucination. There could be metallic taste. There could be muscle twitching. There could be collapse, bradycardia, asystole, arrhythmia. There could be like it happens because of the systemic observation. So high index, suspicion index is required when the patient is in spinal or epidural top up, when it is given. So it has to be very suspicious that there could be possibility of uh, lignocaine toxicity. So it is this part is very very important. So in the exam, usually you find any here, either they would write lightheadedness followed by sedation, and or basically you will find in the questions the keyword will be circumoral or tongue numbness, or another keyword you will find is metallic taste and circumoral or tongue numbness. These are the few, the buzzwords that will help you marking that your answer will be local anesthetic toxicity. Now, what is a treatment? This you have to remember because question comes from every line. So it is the lipid. Now, first of all, what will be the first step? This can come in 2, 3, any exam. First step would be stopping the first of all stop the medication. Then 20%, it is 20% intralipid. You can see it from here picture. 20% intralipid, 1.5 ml over 1 minute time, and this is loading followed by infusion of 15 ml per gram per hour. Infusion is given. Okay, but there could be possibility that improvement is not there. Bolus so what you will do, this is bolus, you will repeat 2 times. You will give a pause of 5 minutes and then you can do it 2 times unless circulation has been restored. Okay, so 2 more doses can be given. Apart from this, if 5 minutes are passed and still the the patient is not reviving, then infusion rate, here we were giving 15 ml, so we will double it, will increase to 30 ml kilogram per hour, but maximum dose would be for 70 kg will maximum dose will be 12 ml per kilogram of body weight. So if the 70 kg woman is there, you can't use it more than 840 ml. So these all numbers you have to remember, not very difficult also. So loading dose 1.5 ml over 1 minute. If no response, then at 5 minute interval you can give it 2 more times. Infusion 15 ml per kilogram per hour, and if there is no response, here you can double it. Okay, and maximum dose calculation 12 ml per kilogram. With this, CPR or resuscitation should continue. So if your answer is CPR and intralipid, answer will be that. It is not only intralipid. And how the intralipids is working? It reverses the local anesthetic cardiotoxicity by increasing clearance from cardiac tissue. So this is the mechanism, the intralipid work, and this is non-specific observed extraction of local anesthetic from cardiac tissue or aqueous plasma. This mechanism is called as a lipid sink. This is called as a lipid sink. Okay, maybe they ask in the exam, or you should know at least how it is working. Intracranial hemorrhage, it could be uncontrolled, usually systolic hypertension. Rupture aneurysm or AV malformation can be another cause. Initial presentation can be maternal collapse, but before collapse, patient will complain of severe headache. Like in subarachnoid hemorrhage, usually the patient has thunderclap as a headache. Okay, so this way something will be there. So another anaphylaxis, very important for both 2 and 3 people. So anaphylaxis, it is this life-threatening generalized or systemic hypersensitivity reaction. What happens? Respiratory, cutaneous, circulatory, and gastrointestinal disturbance and collapse. Why it happens? Because intravascular volume redistribution. Because of that, cardiac output would be less, ventricular failure, and myocardial ischemia will occur. So, how the upper airway occlusion symptoms what? Angioedema, bronchospasm, and mucus plugging of smaller airways. Because of that, there is a problem with the hypoxia and difficulty in ventilation. So you would have seen in anaphylaxis, the person usually first present with the problem difficulty in breathing, and this difficulty in breathing occurs because of all this angioedema, bronchospasm, and plugging of smaller airways. So because of that, all these issues are happening. Then what are the triggers? Latex, animal allergen or food. Incidence 3.5, mortality 1%. Anaphylaxis is likely when following criteria are met. So these are the criteria of anaphylaxis: sudden and rapid progression, very fast it will spread, life-threatening airway, breathing or circulation problem, or skin or mucosal changes like flushing, itching, urticaria, and leg angioedema could be there. So these are the criteria when they are there. So you'll think that anaphylaxis could be a possibility. Now, how you will diagnose it? Mast cell tryptase level help in confirmation of diagnosis. So the three samples are taken. One immediately as soon as possible after resuscitation has started, but resuscitation should not be delayed. Another one 1 to 2 after our the symptoms, and last is 24 hours later. So three times blood like a sample has to be taken to find out the mast cell tryptase levels. So sample like three sample, one at 1 to 2 hours, sorry, one immediate after resuscitation, second sample 1 to 2 hours after start or symptom, and then after 24 hours later. Okay, so this is a new thing I found in the guideline. In previous collapse guideline this was not there. Maybe you will get some question. Now anaphylaxis treatment is very 100 like very important, because if when you are doing part 2, then it comes, and part 3 abcog, like part 3 MRCOG station comes as a management of collapse. But in abcog part 2, like they will ask if every single dose abcog part 2. Okay, so what is the management for anaphylaxis? So what you'll do first, remove the allergen or trigger, and management should be with ABCD approach. Okay, so remove the trigger. Patient usually hypotension is there, so legs are raised to maintain the blood pressure. Then like 0.5 ml of adrenaline, 1 in 100 1000 IM. This dose is very important. You will find a number of questions. Chlorpheniramine in 10 milligram, hydrocortisone 200 milligram. Chlorpheniramine and hydrocortisone can be given slowly can be given IM or slowly IV also. Along with it, airway support is required. Adrenaline can be repeated in 5-minute interval according to the patient condition. And if experienced person is there, even uh, in the apart from this, high flow oxygen is given and fluids are administered. So like some patient may have biphasic reaction, so immediate monitoring for 6 hours has to be done. Now these are the doses. This is the dose of adrenaline: 0.5 ml, 1 in 1000 dilution if given IM. But like it can be given intraven IV also. The dose is say like 0.5 ml, but when you are giving IV, then it should be 1 in 10,000, 1 in the 10,000 solution. Okay, now if you see the picture here, It is 1 in 100. So this is the 1 in 100. So if you are giving it IM 0.5 ml, then this is the dose. But if similar injection in experienced hand you want to give IV, then it is 0.5 ml, but this will be 1 in 10,000. Okay, so this concentration is changing, and all patient they should be referred to the allergy clinic to find out the triggers to avoid similar thing to happen again. So anaphylaxis, it will be ABCD approach. Apart from this, you have to speak about all this, and the drugs and the doses and the mode is very important for your exam. Is it clear? Other causes, it could be hypoglycemia, hyponatremia, electrolyte imbalance, tension pneumothorax, cardiac tamponade, and from anesthetic perspective, local anesthetic toxicity or failed tracheal intubation. Okay, now that's all I have to say about the causes and the management of the causes. So any question till now? Okay, so cardiac arrest. Now, there are two parts are there. Two things you have to understand. This is BLS and ALS. BLS is basic life support. So, what is the basic life support? There is an algorithm is also as in upcoming slides I will tell you. So, BLS or basic life skill or basic life support recognize that there is no breathing or signs of breath, signs of life, then chest compression and mouth to mouth or pocket mask breathing and use of AED like defibrillator will be used. So this is the basic life support. Now uh, advanced life support, there would be intubation because the anesthetist will come and do intubation. There could be IV drug cannula for the drugs. There will be semi automated or manual defibrillators. So like these are the things that is different in ALS and BLS, and many times you will find a question, she was in the community and all these things has happened, then the answer will be BLS, provide the woman basic life support and transfer a shift to the hospital. Now this is the algorithm. Part 3 people, part 2 and no, APCOG 3, APCOG 2 and MRCOG 3. You have to learn this algorithm because they ask you to keep on speaking collapse, and whole 8 or 9 minutes you are speaking only. So unless you remember the sequence and the chart very nicely, how you will speak in the exam only about the collapse. No, so usually it is so first, what will be the first approach? According to first, we have to make it sure that patient should be in safe environment. Then we stimulate and cause assess the response. How it is done? We shake the patient and we say, "Hello, how are you? Hello, are you okay?" So this way we are stimulating and assessing the response. Okay, so patient in safe environment, stimulate and assess the response. If she is responding, put the patient in left lateral position, assess patient blood pressure, fetal heart rate, Muse monitoring, and then had to do examination to find the reason for collapse and treat accordingly. But if your patient is not responding, what you will do? Then you will shout or call an emergency buzzer to pull on a resuscitation team. So in the hospital, it is done by putting emergency buzzer or dialing quadruple 2. So then, and which teams are required? Adult arrest, neonatal, and obstetric teams. Neonatal team you will call only if your patient is more than 22 weeks of pregnancy. Okay, neonatal team about 22 weeks of pregnancy. If you're outside the hospital, then 999 for emergency uh, ambulance, emergency or ambulance, but in between patient to be in left lateral mm, um, position. But if the spine is involved, then attention to be uh, paid for that. If there is no response, CPR to be started immediately. So this is call for help. Then, as I said, we do collapse management in the ABCDE approach. Let me explain you ABCDE. So A is for airway. So what they want, there should be early intubation, or we need to secure uh, airway. So first of all, we have to check whether there is foreign body or any material, anything is there. So how, what you will do to you have first of all to open airway, you have to do head tilt. Now you can see this way head tilt is done, and lift chin. So head tilt, chin lift. And if with this posture, if any of the foreign material or foreign body is there, would be removed easily. So this is head tilt and chin lift. Now sometimes jaw thrust is uh, applied. So that will also help in opening airway. So this is the jaw thrust. Can you see this? So this is they're just putting the finger below the jaw and just lifting it. So this is the jaw lift. Now, if the neck injury is there, if you're suspecting patient can have neck injury, then this head tilt and neck lift, chin lift will not be done. Then patient, uh, in that situation, like, but airway has to airway securing is done. Ideally, airway securing is done by the curved endotracheal tube, but endotracheal tube can only be inserted by anesthetist. If the anesthetic is also not there, it is not done, then supraglottic device can be used. And yes, once the patient like um, uh, once it is there, then a high flow of high level of oxygen would be required, because we already know that women in the pregnancy get deoxygenated very fast. So this is opening of airway, chin, head tilt, chin lift, and this is doing jaw thrust. So first job will be securing airway. Then B for the breathing. So what uh, what you will do, if the open the airway, now we have to assess the patient for 10 seconds by look, listen and feel. 10 seconds by look, listen and feel. Look for chest movement, listen for breath sound, and feel for air. So ideally, like so uh, 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 this breathing can be continued with the bag and mask ventilation or insertion of simple supraglottic airway until the patient is intubated. Because as I already told you, that intubation can only be done by anesthetist, but till anesthetist comes and take care, you have to do this. So open airway, remove all obstruction, give oxygen, and continue with the bag and mask until the patient is intubated. And like so like this also the guideline. So bag and mask ventilation, or if it is not there, then then insertion of supraglottic airway, okay, to be done until the intubation is done, because you have to protect the airway. So this way the breathing will be checked by look, listen and feel. Now circulation. So if the breathing, now what they say, if the breathing is not there, uh, and the airway is clear, that means circulation will not be there. Okay, so what they do for circulation? For circulation, we do CPR, that is a cardiopulmonary. We do cardiac compressions. And how the cardiac compressions are done? That is again very important part. first you remember the ratio 30:2. So 30 will be the compression and 2 will be the ventilation breath. And or like or if the intubation is there, then continuous compressions can be given, and continuous compression will be like 100 to 120 per minute. Okay, before that chest compression 30:2 is the ratio that we are giving. So whenever the compression is given, uterine displacement is done. That I have already told you. Uterine displacement is now recommended uh, for lateral tilt or uh, uh, recommended over lateral tilt, as the chest compressions are more effective. Like previously, what we used to say, put the wedge under it, the woman, but that time it was difficult. But now it has been replaced by the uterine displacement. How the displacement is done? By pushing, to left, or by pulling by one or two hand, by pushing to left, like this is the left, so you are pushing the uterus, or so this is two hand technique and this is one hand technique. Is it clear? So this way, whenever in the APCOG exam, whenever you have to show the complex technical skill and you have to show the maternal collapsation, this part you have to show how you are asking one of your colleague to displace the uterus. Okay, this picture is basically for APCOG part 2, because in APCOG there is a complex technical skill station. Collapse is one of them, and they want to know all steps. Now there will be chest compression. So this way the chest compressions are given. So your arm, straighten your arm. This arm has to be straight. Now you can see both pictures. Arms are straight. You can't. The common mistake people do, they will bend their elbows. Okay, use your weight to put the compression. You have to depress the chest at least by 4 to 5 centimeters, and or 1/3 of the depth. Okay, so this way chest compressions are given. And in APCOG part 2, you have to show how you are doing compression. So press down the 4 to 6 centimeter, release the pressure, allow the chest to rise fully, and compress the chest 30 times. And 2 times there will be rescue breaths will be there. So this way compression is done. Now when okay, for 30 compression you are giving 2 breath. So either you will have any airway adjunct with which you will give 2 rescue breath. If it is not there, then mouth to mouth breath. Though it is not necessary for any exam, but you should know whole topic well. So head is patient's over airway is open, and by head tilt and chin lift, then breath is taken, and mouth from your mouth, and the tight seal is formed um, over the patient's mouth. Then blow at least for 1 second. So he is blowing at least for 1 second, and we need to see the chest wall rise. And if she's like respond, so for 30 compression, 2 mouth to mouth breath, or if the airway adjuncts are there, then you will do 2 ventilation breath. So one cycle of CPR is consist of 30 compression and 2 rescue breath. And like keeping repeating this process, 5 cycle of CPR can be done in 2-minute time. CPR is quite tiring. So another person can also help. Once the patient is intubated, now patient is not intubated, but once the patient is intubated, then there could be continuous compression 120 to 100 to 120, and ventilation breath will be by 10 per minute. Okay, so this way the mouth to mouth or rescue breaths are given. So in the compression part, we are giving 30 compression and 2 breaths. Now, after that, this part is done like as a BLS. After that, what you will do? If the patient is still not responding, then and by that time, cardiac resuscitation will come only. So what they will put defibrillator pad. So usually uh, pads are attached and compression are done with that machine knob only, and this machine usually analyze the heart rate every 2 minutes. So each cycle is 2 minutes only. Okay, so like in between analysis, CPR should continue, and defibrillation energy like 200 joules or 300 monophasic, whether it is a pregnant woman or whether it is a non-pregnant woman, it will be same only. So this is the attachment for defibrillator pad. So that is very important for EPCOG too. Now how the only this is the few slides are there where I am explaining too much. And like defibrillator, so how it works. It will send electric impulse, aim being restoring heart contraction or beating. If it is if it is already stopped, they also prevent arrhythmia or uneven heartbeat. So this is the like defibrillator pad, like this is the attachment of the pads. So usually the pads are attached, and with the machine they will just press the button and give energy. And this is again the either this kind of sticky pads could be there, or this kind of defibrillator pad would be there. So in the exam, usually you have to hold this pad and you have to place on this side, then only you'll be able to give energy. So this much knowledge is important. For other people it is general knowledge, because we anytime we can deal with collapse. And for part 2 EPCOG, this knowledge is very important because they have station. Now after the AED attached, usually we see what kind of rhythm is there. So if it is VT or VF, this is ventricular tachycardia. This way the tachycardia will look, and this way fibrillation will look. If it is there, then shock is given. But if the non-shockable rhythm, can you see here? Asystole, no contraction. So absent ventricular activity, atrial rarely, usually a straight line. So if asystole is there, or if pulseless electrical activity, like patient clinically has a features of cardiac arrest, but ECG is fine. So in these situations, you will not no shock is given here. CPR will resume for 2 more minute time. Why I'm showing you this picture? Because in APCOG 2 exam, you will be shown these pictures also. So you have to analyze in the exam, and you have to decide whether the shock has to be given or not. Then whenever the shock is given or defibrillation is used, some precautions: no one should touch the patient, all conductive surfaces should be away, oxygen should not be there, CTG to be removed, like nothing should be on the touch of the patient. So usually they have a dictum: you clear, I clear, all clear. This is again for the EPCOG part 2. Now this we already if the assessment of rhythm is done, we have shockable rhythm. Shockable rhythm is there. So they will give one shock, 150, 200 joules biphasic, and if it is monophasic, then it is 360 joules. After that, CPR will be restarted. Make it sure no one touches the patient. This is the major safety point. But if you have asystole or pulseless cardiac activity, uh, this is the like asystole or pulseless electrical activity. In that situation, we can't give any shock. So we have to continue CPR for 2 more minutes. Now, if the 4 minutes are passed and the patient is not revived, what you will do? So we have to take out the baby. That means we have to move towards perimortem cesarean section. So uh, perimortem cesarean section, if there is no 4 minute no response, then uh, like then the cesarean section is done, and this is for the uh, maternal reason we are doing, so that aorto cable compression will be relieved, then the resuscitation becomes easy. Okay, so for this perimortem cesarean section, only one instrument is required, that is scalpel, and it will be done with the method what is operator is confident, and here bleeding will be less. Okay, and usually it is done on the site where the patient is. Okay, patient will not be shifted anywhere. So ideally within 5 minutes cesarean section should be done. Why? Because by 6 minutes, if the patient is not revived, there is hypoxic brain damage to the mother. Hypoxic brain damage to the mother. So in sum up, 4 minute, if there is patient doesn't come back, like is not revived, do perimortem cesarean section. And if the perimortem cesarean section has to be done within 5 minutes, because by 6 minutes the patient brain hypoxia will happen. And in the meanwhile, two wide bore cannulas to be inserted, but if it is not possible, then a consideration for CVP or intraosseous or venous cut down can be done. And whenever the you are putting this cannula, this is a question that come in the exam, so you have to put above the level of diaphragm, because if you are putting before the level of diaphragm, then it will not be that much effective. So it is above the level of diaphragm. So two wide bore cannula, or or venous cut down, or intraosseous access, and please put whatever the cannula above the level of diaphragm. So this much you have to know minimum about the perimortem cesarean section. And if the resuscitation is successful, then patient will be moved to theater for completion of surgery. But if it is not successful, that means we lose mother, then coroner to be informed be, uh, before any lines or devices are removed. So coroner to be informed beforehand. Okay, so a lot number of question comes from here, a lot number of questions come from here. And in ABCOG, part 2 exam, and the complex station is there. So they will show you rhythm, and if it is non-shockable, if it is shockable rhythm, you have to give shocks to show your skill. But if it is non-shockable rhythm, then you have to ask them knife, and you have to do cesarean. You have to show as if you are doing cesarean section. Now, during CPR, IV access to be there, high flow oxygen, chest compression, correct reversible causes. Adrenaline can be given every 3 to 5 minutes. So these are the drugs. So so this is 1 in 10,000. So it is IV. So zero point 0.5 ml slowly IV. Dilution has to be 1 in 10,000. 1 in 10,000. So this is adrenaline dose. Coming to imidone dose, it is 30 milligram per ml. So minimum for ABCOG 2, these doses have to be remembered. Now, so I have explained you A for airway, B for breathing, C for circulation. Now I'm moving D for disability, because once the patient is revived, you will look at AVPU score, that is AVPU level, awakeness level, response to voice, response to pain, and unresponsive. This is AVPU. Then pupils are checked for the light, for the reflexes, and the blood glucose level are checked, because sometimes the possible reason could be hypoglycemia. After this is disability. After that, E for the ABCD approach will be exposure and environment. So head to toe assessment to be done, including assessment of reflexes, dignity of the patient to be maintained. So this is complete ABCDE approach for the management of collapse, what your guideline says. This part I have put from the strategy. So that's all I had to say. Anyone, any question? Okay, no question. So this is the basic life support. Okay, this is the basic life support algorithm. I've already explained, so I will not explain that again. This is the advanced life support algorithm. So um, in the advanced life support, like there would be AED attached. They will access the rhythm, and if the rhythm shockable, non-shockable, they will give shock, and apart from this they will consider giving drugs also. So this is the advanced life support. Before that is the BLS or basic life support. These are the from these charts or papers are from UK Resuscitation Council, from UK Resuscitation Council. So only just though you have to remember the chart that is given in the RCOG guideline, but you should know what is ALS and what is BLS. So this is from the guideline. This is from the guideline. So I have explained about the safe environment, stimulation, and shout call for help. I have explained about the airway. I have explained about the breathing. I have explained about the CPR, how it is done. Then this is defibrillator is attached. Then if it is asystole or pulseless activity, CPR for 2 minutes. Here, if it is VTVF, shock is given, monophasic, biphasic. Then CPR to be continued. Then reassessment will be done. So this is the like complete complex algorithm by RCOG guideline. So that's all. Apart from this, it do have a clinical governance part. If the patient is alive, then documentation, debriefing to the patient and family members, supporting staff, and incident reporting for the clinical governance. But if the patient is lost, we are unable to revive her, coroner is informed and embrace is informed. So in cardiac arrest, maternal survival rate is over 50% have been reported. This is written in the GTG guideline. So this I have already told that maternal complex is an incident. So incident reporting to be done. That will help in root cause analysis. All causes of maternal death has to be reported to Embrace UK. So this is also very important to know. Part 3 people have to explain this in the exam. So this is in the summary of resuscitation. So minimum this much you have to speak. So it is ABCDE approach, multidisciplinary team, and management will be in airway with cervical spine control, breathing and ventilation, circulation with volume replacement, hemorrhage control. D is disability and neurological status. E is exposure and environment control. Then after that, assessment of baby may require delivery. Then secondary, so this is primary survey and resuscitation, so that you are looking the patient, and once the patient is stabilized, then you will do secondary survey, top to bottom or top to toe, back to front examination. Sometimes many findings, they are missed in primary survey, so you will get to know in the secondary survey. And then definitive, then identify the cause of collapse and do the treatment accordingly. Okay, so yeah, so this is just in summary. So if you have like, you should know the summary about the resuscitation. Now I'll be going towards the questions. If any one of you have got any query till now, can ask me. So this I have explained, uh, maternal collapse from strategy, from GTG, and from UK Resuscitations Council. Also, a few parts are taken from internet for teaching. So any question, or should we move ahead with the questions? Okay, that's fine if you don't want. So a 39-year-old woman with elective cesarean section, she was well, uncomplicated pregnancy, she has cesarean section. When the incision was made, baby delivered, she complains unwell, suddenly goes into cardiac arrest. What is the cause?
This is amniotic fluid embolism within 30 minutes of delivery.
Yes. So high risk factor is maternal age, advanced age, and cesarean section. Okay. So this is amniotic fluid embolism. Low risk primipara, vaginal birth, second degree tear. She after 1 hour she is getting repaired for the suture in room. Midwife used local anesthetic and gas and air for analgesia. After 5 minutes, patient complains lips are tingling in lip. She become confused, unconscious. What is this? Circumoral tingling. I just spoke this keyword.
Drug toxicity due to lignocaine infiltration.
Yes, it is local anesthetic toxicity. Okay. You have been asked to see unbooked patient. She is collapsed. Constant abdominal pain, no vaginal bleed. Gravid uterus, unable to discern presentation because of woody abdomen. She smells of cigarette. Answer.
Abruption,
Wood-
ma'am.
Yes. Woody uterus and cigarette smoking are the keywords. So, patient 37-year-old, 6 days following vaginal birth. She has induction at 38 weeks for preeclampsia, no significant blood loss. She had central chest pain for 12 hours. She is 38 BMI and smoker. Cause of collapse. Clue: 38 BMI, smoker, central chest pain, preeclampsia. There are the four things. Age of the woman 37. Now you should tell me. Okay, guess only. Some guesswork.
Myocardial infarction.
Yes. What? No, no, not myocardial infection. It is thromboembolism. Okay. So, 38 BMI, age more than 35, and smoking. So, it could be another differential diagnosis will be myocardial infarction. But if the myocardial infarction is there, they will give you like pain radiating towards the hand, or they will give you some ECG, or they will give you some troponin factor, troponin something. So some clue will be there. Here they have not given, or some cardiac disease history. Here they have not given anything. Okay. Now, the patient is delivered with a ventus 4 hours ago. She had syntocinon infusion. Patient tells you, midwife tells you, patient just stood up to take shower and she fainted. Why she fainted?
Vasovagal faint.
Yes, very good. It has to be esophageal because of the when the patient is lying for longer time, there is a pooling, and suddenly if the patient wakes up and stands up, there would be vasovagal, and we already know that the vasovagal faint, and also the epilepsy are the most common causes of collapse. So patient has fourth child. She has first degree tear that was not sutured. She gives history of collapsing at home. She feels hot to touch, look pale, pulse rate 120, BP high, 80 by 40, temperature 37. So keywords: 4 days after delivery. That means time is there. Feel too hot. She's feeling hot. Tachycardia and hypotension.
Sepsis?
Yes, sepsis. It could only be sepsis. There is no confusion. Uh, what the temperature is fine, but there could be possibility that temperature is a little on a lower side. There could be possibility that temperature can be high and low. Okay, and all these features are there. 4 days after vaginal birth, like time, she has got time for develop infection. Hot and touch, when the patient will have hot and touch. Tachycardia and hypotension. Hypotension is very important part. So it is sepsis. Okay, so ambulance bring 20-year-old unbooked patient, 27 weeks pregnant, following a collapse on street. She smells of cigarette. Examination is normal. Non-tender uterus. She is asking for pain relief, but she doesn't want any paracetamol. Her effect is somewhat confused. She hugs agency midwife. Recognizes her from previous attendance in different hospital. Any guess?
Ma'am, it's only the guess. Could be hypoxia.
No, no. Now you can see she collapsed on the street. So that means she's not on the home. Then she smells of cigarette. That means she's a smoker. Then examination is fine. There is no problem. Baby is fine. Uterus is non-tender. She doesn't want paracetamol. Why? Because maybe with the paracetamol she's taking something that would have reaction. She's confused. She knows the agency midwife, so she's known to social worker. What it could be? She's a drug abuser.
Then it would
So
be toxicity.
it would be toxicity.
Okay.
Okay. So scenario suggests of toxicity, likely explanation, possibly alcohol or other drug. Full neurological examination is indicated with a full social service workup. These kind of question come in, as EMQ in MRCOG part 2. And like if you really don't scratch your head, answering becomes very difficult. So you have to really, think all over the situation, then the answer will be this. So a 37-year-old woman, emergency department, acute chest pain, shortness of breath at 32 weeks of pregnancy. Whilst waiting, she suddenly collapses. Junior doctor says she doesn't find any cardiac output. Crash team summoned and CPR started. All teams are alerted. No response at CPR 4 minutes. Very easy.
In section, perimortem cesarean section, emergency department,
Yes,
where she is.
there could only be only one answer here. 28-year-old woman admitted in labor ward with a history of sudden abdominal pain. Abdomen pain is there, but bleeding is not there. She is having high blood pressure, tachycardia. Abdomen is hard. A little tricky question, but it is very good question because people make mistake here. At least one clue, like people, you guys can guess
Emergency,
it.
emergency cesarean section in operating theater. Scenario for abruption.
Yes, scenario is for abruption, that is fine. But will you take patient for cesarean section without checking fetal heart at 30 weeks of pregnancy? So answer is obstetric USG.
Okay,
Yes,
obstetric
because
USG.
at 30 weeks, if the
30
patient,
weeks.
yes, at 30 weeks or whatever the weeks of pregnancy, if the patient is coming to
We
me,
have to confirm. Yes,
yes, without confirming fetal heart, abruption patient, we will never take for cesarean. So
yes.
the question appears to be very easy.
Ma'am, a
People,
very long list of the options make confusion for everything. This is the main issue with this exam that EMQ got very long list of options.
yeah, therefore, like they want to keep a standard of MRCOG.
Yes, exactly.
We can't help it. Nothing can be done.
Yes, yes.
Nothing can be done.
Okay.
18-year-old previous history of pulmonary embolism, delivered by forceps, sustained tear, local anesthetic infiltrated. She suddenly turns blue and become unresponsive. So what has happened?
And this is lignocaine toxicity, and we will give intralipid.
Very good. This, oh God. So this, so I have put answer only. So 26-year-old asthmatic woman. She's, no question I have. Okay, question is, no question I have put. Okay, so multiparous asthmatic, now 34 weeks pregnant, working in garden. Suddenly she collapsed, turned blue. So she is in the home and she collapsed. So answer will be basic life support. And this part of guideline will answer. If the maternal cardiac arrest occurs in community settings, BLS should be administered and rapid transfer to be arranged. Okay. This question many people they do wrong. So this I have already told. So this is like UK resuscitation guideline, adult basic life support in community setting. 26-year-old woman, uncomplicated vaginal birth, placenta is delivered, she become unresponsive, heart rate 40, BP this much, estimated blood loss 200.
Ma'am, here is confusion between amniotic fluid embolism and pulmonary embolism. But her
Why
heart rate is 40.
see, in any embolism hypoxia will be there. There is no hypoxia. So both cannot be the answer.
Okay. Then
Okay.
uterine version. Oh, sorry, it is after the placental. It is uterine version.
It is inversion.
Yes.
It is inversion only. Because the blood pressure is very blood loss is very less. Why there is so much bradycardia? Because of vagal stimulation. Here vagal
Yes.
stimulation had happened. Because of that this
It is,
picture,
ma'am.
and
It is neurogenic shock, what we call the neurogenic.
the vagal stimulation.
Yes.
Okay, so patient went induction of labor for post date. 3 hours, second stage, deliver 4.2 kg. Collapsed immediately after delivery. Okay, what it could be? Previous cesarean section, sudden collapse.
Uterine rupture. Rupture.
Yes, uterine rupture. 42 years old woman delivered using forceps at 36 weeks. She is in active stage of labor. 40 minutes after she fall onto one side and become unresponsive. Why the patient will move on one side? Some neurological problem. Intracranial hemorrhage. Okay, this is the picture of bleeding inside the brain. Stroke, falls on one side. 17-year-old girl, induction of labor, PORM. She came to casualty 2 weeks after, complaining of palpitation, general unwell feeling. She has 90 heart rate. Blood pressure is 110/70. She assured and sent home. Late in the home, she collapsed. Why she collapsed?
Sepsis.
Sepsis. Because prolonged rupture of membrane. She is coming after 2 weeks, feeling unwell. These are the buzzwords towards the answer. So a 22-year-old woman and attends labor ward after breaking waters. Group B positive, prophylactic antibiotics followed by oxytocin augmentation. She is complained of shortness of breath, flushed and agitated. Sudden breath
Anaphylaxis.
anaphylaxis. So anaphylaxis features are wheeze, itch, edema, stridor. To a 16-year-old with acute onset of backache, she has monochorionic pregnancy, tachycardia, hypotension, abdomen intense, and there is no vaginal bleeding.
Abruption again, ma'am.
Abruption. Yes, it is abruption. Because what it could be? Abdomen tense, no bleeding. Okay, 34-year-old woman transported to ambulance and collapsed 6 days after delivery. Prior to discharge, she was uneventful, feeble pulse and non-recordable BP. So what you will do? So patient came in collapse. What you will do?
Option M. Secure
Yes, it is.
airway and oxygen.
Yes. ABC is the first management. Okay, so patient is coming following cesarean section. Complaints of myalgia, headache, dehydrated. Temperature is 104. Signs of cerebral irritability, diffuse tenderness over lower abdomen with contracted uterus. What you will do? What is the diagnosis?
Ma'am, can't understand this scenario.
So It is meningitis. Dehydrated, febrile, temperature so high, and irritability. So, irritability occurs because of that neck stiffness will occur. So this patient will require ICU admission, hydration, and supportive care. Supportive care means antibiotics.
Okay. Diffuse tenderness. The thing which is written diffuse tenderness in the lower abdomen, it's pointing towards which thing, ma'am?
Infection, what it could be? Patient is having infection, meningitis. See the temperature.
Infection, diffuse tenderness is noted across lower abdomen. This has confused me.
Yes, some like tenderness is a marker of infection only, but more like most can be associated endometritis also. So they are giving like clue to reach diagnosis of meningitis. There could be endometritis, so infection is there in the body
Okay.
after cesarean, so it has reached to brain, so meningitis. The
Okay, okay, okay. Now it
so
is
that
explained. Yes.
26-year-old with complaints of confusion, palpitation. She is type 1 diabetic on insulin. She is dehydrated, tachycardia, tachypnea. Urine shows ketonuria. Only one diagnosis could be there.
Ma'am, initiate sliding scale insulin protocol.
It could not be the answer. So, high dependency uteri, sliding scale, sliding is initiate sliding scale insulin protocol. But in DKA, they are not doing any sliding scale. If you read the DKA talk, or you go to the DKA diabetes class, I have shown you the picture of diabetic ketoacidosis management. So it will be they will give insulin infusion, then they will reduce insulin doses. So they're not giving sliding scale there in diabetic ketoacidosis. Because of that, IV sliding scale is not the answer. Answer will be supportive care. And apart from this, like supportive care would be like they give insulin high dose, then they taper it, and they give hydration and potassium also. So this will be the answer. So this way people do mistake. If you don't know the management of diabetic ketoacidosis, everyone will put this answer sliding scale, but sliding scale will not come here. Okay, diabetic ketoacidosis, bolus of insulin is given, and then it is tapered. So it is different approach of insulin. Therefore, the answer is this. Is it clear?
Yes, ma'am, clear.
Yeah, you can go to the diabetic ketoacidosis diabetes class. I have put the diabetic ketoacidosis management there.
Okay, okay.
Okay, so the patient rushed to emergency in a collapse. She is smoker, complained of severe abdominal pain, rigid uterus, fetal heart 100 only. Now what you will do? Here they have given fetal heart also. So
Initial stabilization and category 1 cesarean section.
yes, so this is abruption, but we have live baby, so we'll stabilize the woman and do cat 1 cesarean section. Primi gravida induced 2-week postpartum oxytocin infusion. Heartbeat is monitored continuously. Last examination 5 centimeter dilatation, big bag of membrane. Membrane ruptured, liquor clear. Sudden chest pain, breathing difficulty. Now you can see here she has breathing difficulty. Pulse is this and BP is this. So hypotension, hypoxia and hypotension. So what is the next step? So what is the diagnosis
Ma'am,
first?
amniotic
Yes.
fluid embolism, ma'am.
Yes. What is the
Secure
next step?
airway, oxygen, and IV access, ma'am.
See, they're asking next step. Next step
Okay,
will
ma'am.
be call for help.
Okay, ma'am.
Okay. And if they
Yes, ma'am.
tell management, then it should be ABCD approach.
Okay.
Okay. This way the
Mm.
answer changes. So 18-year-old woman with a history of giddiness collapses at GP surgery, initial resuscitation done, transported. She has known history of substance abuse. So what to be done? So here the patient is all initial resuscitation done. Now she's coming to you. What
Ma'am,
you will do?
perimortem cesarean section, ma'am.
28 weeks perimortem cesarean section. Initial resuscitation is done. That means patient resuscitate. They have done basic resuscitation. That was fine because after resuscitation they have transported the patient. So that means patient has been basic steps are done only. So that means patient is revived. Only revived patient you
Now,
can.
ma'am, documentation.
No, high dependency unit. Follow up of
Okay.
post collapse treatment you will do, and post collapse patient will be kept in HDU, and whatever the cause of collapse, according to that treatment will be done. Because of that, HDU admission and supportive care. So this is you have got the scenario where the collapse treatment has already been done. Patient is revived. Now they are shifting. They have done initial work. Now you do in the hospital. So what you will do in the hospital? You will admit the patient. You will examine the patient. Then you will whatever the treatment. What is the cause causing collapse? You will treat that. Because of that, this is the answer. Okay, so now I think I'm about to finish. So, a 38-year-old woman, smoker, sharp chest pain accompanied by sweating palpitation. ECG shows ST elevation. Now you know when the ST elevation will occur. So now you can see here the MI is the answer. They have given ECG finding. So you can diagnose the MI, and in MI what you will do, you will do coronary angiography. So this way the answer, like they will give you a clue where you are going. In previous question, I don't know what was the answer. We have discussed one of such scenario, but in that scenario, central chest pain was there, but ECG they have not given. Okay. So like similar kind of scenario you find in your exam EMQ, like it will be collapsed patient, or almost similar kind of scenarios are there. So you have to find out buzzword to finalize your answer. 23-year-old woman, RHD, she has rheumatic heart disease, complains of weakness and numbness of her left arm. Okay, so she has got problem in the arm. 10 weeks pregnant on thromboprophylaxis with replaced mitral valve. She has vital signs, stable vital signs. So what she's having? So if
Stroke,
upper arm
ma'am.
huh?
He has gone for some thromboembolism. Stroke, ma'am.
Stroke. There could be stroke only, because of that it is coming in the
Mm. Mm.
numbness is coming. So
Mm.
it will be
So,
coronary angiography. No,
so she has to be
cerebrovascular.
given. Uh,
No, it could be
okay.
a cerebrovascular event to be excluded. So MRI
Mm.
brain.
Okay.
29-year-old woman, 18 weeks. She has gone for amniocentesis. She complains of chest tightness, breathing difficulty, and become unconscious. So what you will do? So patient is unconscious. How you will
ABC,
start?
ma'am.
ABC.
ABC.
Yes, ABC. Now, patient has got like lignocaine toxicity. So, what will be the recommended regimen? This is the last question, I think. It is 20% intravenous
D.
lipid,
D.
1.5
D,
milligram
ma'am.
over. Yes, D is the answer.
Thank you,
Okay,
ma'am.
that's all for it. So, any one of you have got any question? Okay, people. Bye. Thanks
Thank
for
you so
joining.
much, ma'am.